Alrighty, so we'll get started. Thank you for joining today's conference. This particular session is Innovations in Pediatric Kidney Transplant, and I'm very honored to introduce our speakers, Dr. Rouba Garro, Medical Director, Kidney Transplant Program at Emory University, as well as Dr. Chuck Varnell, Assistant Professor of Pediatrics and Associate Medical Director for Kidney Transplantation at Cincinnati Children's Hospital. Thank you both for being here, and we're excited to get started.
Thank you, Amanda, for the introduction and for inviting us. We are pleased to talk to one of the closest group of people to our hearts. So today we will be talking about advancing pediatric transplant care through network-based learning. So first, I will introduce Improving Renal Outcomes Collaborative as a learning health system, and then describe how collaboration in a learning health system supports quality improvement, and then how data that are generated through the collaborative are used in research and improve patient care. Then Dr. Varnell will discuss the role of the learning health system during crises like COVID-19 pandemic. So why do we need to advance care for children with transplant? And that's because expected remaining years of life in children, although improved improved with transplant comparing to dialysis, yet it's still below general population. So we're still not doing very well. And our children, as you know, are expected to live longer, so we need to do better when it comes to graft survival. So there is pressure on us as a pediatric transplant community to do better, yet we have unique challenges in pediatric transplantation comparing to adults. One of the challenges is that we are small. I mean, we have low volume, and pediatric transplants are uncommon. So typically we average 750 transplants per year, which is nothing to comparing to adults who average 30,000 transplants per year. So one large adult transplant program typically transplant around 400 patients per year, so almost half what we do all as a nation. So because our volume is low, many pediatric transplant programs are small. So if you look at this pie chart on the left, in 2019, there were 99 pediatric kidney transplant centers. And almost half of them, 44 centers, they transplanted only, so less than 5 patients per year. The other 29 transplant up to 10 patients per year. And because of that, almost half of our patients, so you can see more than half of the pie, so those are the patients transplanted in centers who do less than 10 per year. Another important challenge is that children are constantly growing and changing, and we have to constantly adjust management according to their growth and needs. So there is no dull moment taking care of our patients. And throughout growth and development, there is ongoing shift of responsibility, as you know, from caregiver to patient. And as most of you know, transferring responsibility is a very delicate process, especially in patients who have chronic disease, and it requires multidisciplinary support. Also, many of our teenagers and young adults engage in high-risk behavior that add an extra challenge to their already complex care. So as a summary, we have small volume and we have subsequently limited data in children. We have pediatric specific issues, and we have small centers, which increase the need to having multi-center collaboratives to guide our evidence-based management in pediatric transplantation. So historically, we have had registries that provided insight into pediatric transplantation outcome, like UNOS, NAPRITEX. There are some limitations to these registries, including that they cannot provide real-time feedback. There is some lag to clinical implementation, and they cannot provide practical solutions to improve care. So what can we do about that? Learning health system can provide solutions to the limitations I discussed with the previous, with the traditional registries. So what is learning health system? Learning health system is an organizational architecture that supports communities of patients and families, healthcare professionals, and researchers that collaborate together and produce large data. So how does it work in learning health system? So we use our daily clinical practice to generate data that we use to assess performance and subsequently create feedback for learning and improvement. And that creates knowledge. Sorry, did I do something here? Can you see my slide?
There we go. You got it.
Okay. Yep. So we generate data that we, as I said, use to assess our performance and provide feedback and give us the knowledge that subsequently we use to improve our practice. So having that in mind, the pediatric transplant community recognized the need to build a network-based learning health system for pediatric transplantation. And Improving Renal Outcomes Collaborative formed in 2015 with a mission to partner with patients with kidney disease and their caregivers to achieve health, longevity, and quality of life equivalent to the general population. So the first design meeting happened in 2015, and we had a lot of heated, emotional, and productive discussions. There were a lot of sticky notes. And as a result of those two design meetings we had, we as a collaborative identified our initial IROC focus areas. The first was to improve blood pressure control, followed by reducing acute graft rejection, and subsequently enhance quality of life for our patients and families. So initially in 2015, we were 15 centers. 7 years later, we are now 38 centers from all over the country with more than 435 participants, and more importantly, 57 parent, patient, and caregivers. And almost 53 of pediatric patients transplanted are transplanted at the IROC center. So what have we done as a collaborative so far? The first quality improvement project was to standardize blood pressure measurement across 17 pediatric transplant centers. So why blood pressure? And that's because hypertension post-transplant is an important common cardiovascular risk factor. So this is a British study where they looked at 428 patients in their registry, and they found that 40% of their patients had uncontrolled blood pressure. And more importantly, a third of those patients with uncontrolled blood pressure were not on medication. It means it's under-recognized. And half of those who are on treatment, so we know they have blood pressure, their blood pressure was uncontrolled. So we're not doing well. So why does it matter to have uncontrolled blood pressure? Why the fuss about this? And that's because uncontrolled blood pressure has shown to be associated with poor patient and graft outcome. So this figure, without going into the details, the top curve represents the graft survival of patients with good blood pressure control. And those patients had better graft survival. Their kidney lasts longer than the lower curve, than the patients. So the lower curve represent patients with uncontrolled blood pressure, where they had worse graft survival. Their kidneys lasted less than, shorter than the other patient group. With that in mind, IROC decided to focus first as a collaborative and focus their efforts on increasing blood pressure control, and as it's the lowest hanging fruit. And the first step to achieve improvement in blood pressure control was to achieve accurate blood pressure measurement, because we want to generate data that is reliable, that we can use to evaluate blood pressure control. So we, as a collaborative, came together and agreed on protocol for appropriate blood pressure measurement. And centers were giving two options. Option number one, to use automated blood pressure. And if the blood pressure is high, then to use manual blood pressure. The option number two was to go directly to manual blood pressure. But regardless if you use automated blood pressure or manual blood pressure, 5 elements need to be met for the blood pressure to be accurately measured, including using the right side cuff based on the arm circumference, using right upper extremity, resting for 5 minutes before checking blood pressure, and then averaging 2 readings. So this quality improvement project took place across 17 centers who participated in it, and each center developed their own process to improve blood pressure measurement. And the goal was to evaluate at the end of this process and at the end of this QI project, the percent of visits with appropriately measured blood pressure across these 17 centers. So although this sounded like a very simple project, but really a lot of work took place across all centers. And this is not to scare anyone, but this was complex. It required a lot of work, including getting buy-in from stakeholders, training staff, getting adequate equipment, and working in adjusting clinic workflow. And as a result of this effort across the collaborative, we were able to increase the percent of accurately measured blood pressure from 11% to 78% after 10 weeks of intervention, and we were able to sustain it for another 10 weeks. So what did we learn from this first QI project? We learned that separately, we were not doing well with blood pressure measurement. But together as a collaborative, we were able to improve blood pressure measurement. And more importantly, we learned how to work together as a collaborative. So what was the next step? The next step was to use this data that we generated from having appropriate blood pressure measurement to evaluate blood pressure control. And that's where, kind of a research studies took place. So we looked at blood pressure control across the 17 centers. And we included almost 900 patients who had 1 or more visits with appropriate blood pressure measurement from these centers. And what we found is that hypertension is common in children with kidney transplant, similar to what the British Registry found. And 60% of our pediatric kidney transplant patients had hypertension. And the hypertension was defined either having high blood pressure during clinic or being on medicine for blood pressure. So hypertension was common, and more importantly, only 50%, so you can look at the circle, and the green shows the number of patients with normal blood pressure. So only half of our patients had normal blood pressure. Despite being on medication, we still have 50% whose blood pressure is not well controlled. And we looked at different risk factors that is associated with uncontrolled blood pressure, and we found that obesity, being obese, And age more than 18 was associated with likelihood of having uncontrolled blood pressure. Also, we showed a lot of variation in blood pressure control across all centers. So you can see it's all over the map. The small circles are the different centers, which shows us that there is a lot to learn from each other and play to each other's strengths, because some centers, regardless of the volume, big or small, they were doing better than others. So what was next for IROC? So the next step was to reduce acute rejection. We worked together on improving blood pressure control, and we're still working on it. The next step was to reduce acute rejection. And the first thing we targeted is trying to decrease acute rejection rate in the adolescent area by addressing barrier to adherence. And the reason behind that, you can see this figure. This line represents the rate of rejection, and you can see it's slowly going up with the increase of age, and you can see it's the highest around the teenage and the adolescent area, and then it starts going down after 24 years of age. And that's because of the non-adherence to medication during that phase. So the first goal for the collaborative was to address barrier to adherence in order to decrease acute rejection. And that was presented in detail by Dr. David Hooper last year in this conference, so I'm not going to go into details. But we are still currently working as collaborative on identifying barriers to adherence in each center, and then creating and developing patient-centered shared decision-making for barrier-specific intervention. And we apply consistent implementation for the treatment pathways. And this figure represents the ongoing work in each center in trying to address the barrier to adherence in each clinic, having action plan, and then continuing to follow up with the patient. And the data, I mean, there was a pilot result from Cincinnati that they published a few years back, that they showed the green line showed the time of the intervention when they started assessing barrier to adherence and intervening, and this red line was the rate of rejection. And you can see they demonstrated they were able to nicely decrease rate of rejection by implementing these interventions, and they were able to increase the days between rejection episodes. So there was positive results according to their pilot results, and the collaboratives continue to work on this, and hopefully will generate data from that. Another area of interest when it comes to, and that needs a lot of work in pediatric transplantation, is the transitioning time to adult care, because it's very critical time, and we tend to see higher rate of rejection and graft loss around that time. It can be rocky, and we have a lot of work around transitioning, and our community engagement work group has been very heavily involved in the work with the transitioning, and they are working on developing a guideline for transition. They already worked on having educational material for rejection as well that we share with our patients, and we appreciate all their efforts and input. So how else can we reduce rejection and improve graft outcome? And that's by early detection and treatment of rejection. So currently, kidney biopsies, as most of you know, are the gold standard to diagnose rejection. Some centers, they use even surveillance or protocol biopsies at certain times to detect early rejection. The issue is that it's costly and invasive, and it's not convenient for frequent monitoring. We cannot keep doing the biopsy just to monitor for rejections. And that highlighted the need of having some non-invasive biomarkers, some tests that we can use to detect early rejection. And it could be blood tests, and or urine test. And the transplant committee has been working hard on developing some of those non-invasive biomarkers for the last decade now. One of the front runners when it comes to biomarkers is donor-derived cell-free DNA. And so what is donor-derived cell-free DNA? And it's basically, it's a DNA fragment that is released in the recipient blood from the injured graft. So if you look at it, it's like if you look at the circle on the top, so if the graft is injured for whatever reason, rejection is one of them, it's going to release some of the DNA from the donor into the circulating blood of the recipient. And then you can look at so this is in red coming from the donor, so you can evaluate the ratio comparing to the recipient donor. So if the ratio is high, it means that it's injury, versus when there is no active injury of the graft, you will see less of this DNA fragments in the blood. So there are a lot of adult studies that took place to evaluate the right cutoff for this cell-free DNA. And based on the adult studies, currently they use 1% cutoff to diagnose acute rejection. But this is still, it's a working process, but it has some promising data where they showed that this biomarker, the cell-free DNA, starts rising. You can see in this figure, it starts rising even a few weeks before the active rejection. And what's nice about it, that it starts going down with treatment. So it can be used as well to monitor the effect of treatment for rejection. How about children and pediatric studies? Really very limited and very small studies. There is actually one small study looked at it and used adult derived cutoff. And having that in mind, that's why IROC currently is working on a study to evaluate the use of cell-free DNA in pediatric kidney transplant recipients. And the plan is to have 3-year prospective study, including almost 20 centers, 400 recipients, and almost 600 biopsies. The plan is for each participant to give 1 or 2 tubes of blood at the time of the biopsy, either the protocol or the rejection or the indication. And then comparing the results of the cell-free DNA with the biopsy finding, and then comparing it and look to the outcome. So the goal is hopefully is to have pediatric specific cell-free DNA diagnostic and prognostic models. So we will be able to have a cutoff to diagnose rejection and certain cutoff to predict the outcome of the graft. So again, this example highlights the importance of having an infrastructure like IROC or any learning health system, so we can use it to run some innovative studies that makes a difference when it comes to our patient outcome. And with that, I will pass it on to Dr. Varnell to discuss the role of IROC during COVID-19 pandemic.
Thank you very much, Rouba. It's an honor to be able to speak to you guys here today about some of the work we've done in IROC. And Rouba's already shown you some really great clinical projects that we've gone through within the Learning Health Network to try and solve big problems within pediatric kidney transplant. And so as I'm sure everyone here is aware, we have this great global pandemic that started a few years ago, and we weren't really sure what to do with it. And so IROC really took that to heart to try and answer these questions. And so if we just go back and think to March 2020, you know, some of the challenges for me as a physician and for my colleagues is, well, now everyone's been told to work at home. We've got these virtual visits set up. How do we figure this out? You know, all of our patients are immunosuppressed and they're really interested in staying safe, keeping their loved ones safe. How do we answer these questions? And then one of my other bullets is I at the time had a kindergartner doing virtual school, which was a nightmare. So trying to juggle all of that together at the same time. And so at IROC, we've already talked about who we are. I can skip through this pretty quickly. We set up this March virtual call where we had physicians and other caregivers within the coasts come talk about what their COVID experience was like. So Dr. Chaudhry and on the West Coast at Stanford and Dr. Singer on the East Coast came to talk about the COVID patients that they were seeing. Because at the time, I'm practicing in Ohio. I'm not sure what it was like for Rouba and Atlanta, but we hadn't quite seen the numbers that the coast were getting yet. And so this was a great way for us to be informed by our colleagues. Hey, this is what we're seeing. This is what it looks like. Potentially some treatments that we've tried. And that call sparked two projects. So patients and families were on that call. They were hearing the same talks the physicians and other members of the healthcare team were. And they had questions for us, rightfully, that we weren't ready to answer. And then secondly, we wanted some really specific data questions. So how are patients doing? Who's being tested? How prevalent is this? What are the outcomes when patients get COVID? And so we utilized all the data that was already in the IROC infrastructure, created a supplemental data collection tool, and we sent this to all the participating centers. And so just to the first part for the patient-family experience, surely all questions that I'm sure people on this call have asked themselves or asked their care team. So how do we answer these questions? So IROC teamed up with transplant families and with a bunch of other networks within solid organ transplant in children to develop guidelines. What do we need to know to take care of my child? How do I stay safe when schools open back up? How do we go to school safely? And so all of these sheets were made available on the IROC website, also from the websites of these other centers that we've mentioned. And so to get there, if you're interested in looking at this later, I've got the web address on the top of the slide, irocnow.org. There's a little button up there called COVID-19. You can click on there and get to resources, and that brings you to this page. You scroll down. There are lots of resources that we've created with these other networks and collaboratives that we've made available to anyone who can get to this website. So by all means, please check them out. So for our data question, we wanted to know what are the testing indications? What are the treatments people are doing? And how are patients doing once they've been infected with COVID? So we collected all this data. What I'm about to show you is data that's all prior to vaccine availability, so pre-vaccine data. You can see here from March through February of 2021, the gray bars are all the patients within IROC participating centers that were tested for COVID, and the small gray box on top represents how many were positive at the time. And I've tried to overlay on the bottom if you can see the various surges as the CDC defined them. And if you split the groups into older and less than 12 years old, the patients greater than 12 were more likely to be positive at almost every point during the study. When we look at the symptoms patients had, these are pretty nonspecific. These are the same symptoms for any other upper respiratory infection or GI illness. They're very common within pediatric medicine. But I wanted to point out especially that up to a third of these patients at the time that they were tested for COVID, these are all positive patients, had no symptoms whatsoever. And so I don't think we have great data about how common asymptomatic COVID is within transplant patients. It probably doesn't mean much for the patient themselves. So if you're asymptomatic and have COVID, I'm not sure that that's good, bad, or indifferent. But when we think about the public health response, wearing masks, trying to limit spread, this certainly plays into it. When we look at the outcomes for our patients, the large majority of patients over the whole period, 133 of them just needed supportive care with no specific other interventions. About 10 of the patients total had their immunosuppression reduced, which was done for various reasons. As far as the highest level of care, so the majority of these patients, 103 out of 133, were just seen on the outpatient side, or maybe weren't even seen at all. 23 of them were admitted to the hospital in a non-ICU setting, and then 7 patients did require some ICU level care. And I'll tell you that number is a little skewed higher because early on in the pandemic, there were several hospitals reporting that before we really knew what COVID was going to be like, particularly for immunosuppressed children, everybody was going to the ICUs. And then that quickly kind of de-escalated once we had more experience with the infection. When we look at the outcomes of the transplants, the majority did not have any complications for the transplant at all. There were about 15 various cases of rejection that were associated with the infection. We don't have granular enough data to say the COVID caused a rejection episode, but they at least were temporally related. And one patient unfortunately lost their transplant after a new immunologic, what's called a immune-mediated glomerulonephritis happened after the COVID. Again, it's hard to know, did one trigger the other? We suspect it may have played a role, but certainly need more studies to tease that out. And then when we think of the outcomes for the patient, so 131 of the 133 globally, other than what's mentioned with the graphs, the patients themselves survived. One of our patients that's reported did have MIS-C, which is the multi-system inflammatory syndrome in children. And then one patient did unfortunately die as a result of the COVID infection. So they were an older patient, had more traditional adult risk factors and comorbidities for more severe COVID outcome. And that patient, like I said, unfortunately did not survive. So when we think about traditional infections like the flu, the flu tends to be bad in children. It tends to be worse when you're immunosuppressed. And so we assume that COVID was going to be very similar. But as it turns out, when we compare transplant patients and immunosuppressed patients to the general pediatric population, there doesn't seem to be a big difference between the immunosuppressed children and the non-immunosuppressed children. So why is that? Well, in adults in 2020, 1 in 6 deaths in an adult kidney transplant recipient was because of COVID. And the risk factors that make the disease more severe are patients with obesity, with diabetes, if they have cardiovascular disease, or for age greater than 60. We have some theories as to why this is different for children. We think maybe the comorbidities are just different. In general, they happen to be younger, they have less chronic disease and less time of that chronic disease. And a lot of our patients are otherwise healthy with the exception of their kidney disease. So I tried to look at what the adults were doing when we think about what happens when patients get diagnosed with COVID. There's not a lot of stuff on immunosuppression management. What should we be doing as providers, particularly in immunosuppressed patients? There is some data that perhaps steroids and giving steroids to patients that are sicker, this chart's just showing that if you needed a ventilator or if you needed oxygen, being on steroids led to a lower mortality risk. And then because of that study, a bunch more people tried to replicate giving steroids in this meta-analysis. And it again points to the fact that maybe being on steroids, which we all know is a form of immunosuppression, may be beneficial in patients with COVID. And so, when I was speaking to some of my peers recently about this work, the adults are generally reducing some of the immunosuppression, but only in the most severely ill patients. And there's a trade-off here, right? So if you have COVID, and we want to completely withdraw or reduce your immunosuppression, we're potentially letting the inflammation get worse, right? And if we don't have these anti-inflammatory agents, you could potentially get sicker from the COVID. We just don't know how to answer that question. Or if we keep you on immunosuppression, we're theoretically decreasing your body's ability to mount an antibody response, particularly in people that have low lymphocyte numbers. So we're still trying to figure this out. So what do we do with a patient who has COVID? I'm not sure how many people on this call have had a loved one or if they themselves have experienced COVID. But in general, the pediatric response, and this is all from the data we collected through IROC, this is kind of what we've been doing. If the patient's sick enough to require immunosuppression reduction, generally we'll stop one of the medications for about 2 weeks. And if you're even sicker, then we have to stop all the meds. It's more important to save a person's life than it is to save the transplant. But we have to balance that, as I said, with post-COVID development of maybe potential antibodies, maybe rejecting. There are a bunch of meds that come out that end in MAB, NIB, VIR. I didn't list them here because they show up and then there's a new variant and they don't work anymore. And really leaning on your healthcare team to know what are the risk benefits here. Is it right for the patient at any given time to take? And then I'll just say a word about Paxlovid because most people have heard of this. Paxlovid is a very strong inhibitor of an enzyme called CYP3A4, which is what metabolizes tacrolimus. And so if patients are taking this medication and their transplant teams don't know about it, you can have TACR levels go very, very high. So I heard at least one of my colleagues report that their primary care doctor had started a patient who's on tacrolimus on Paxlovid after being diagnosed with COVID, and their TACR level several days later, having been off TACR, was over 100. So pretty significant TACR metabolism interference. And so what else can we do? We're encouraging vaccination as best we can against COVID-19. Pediatricians and pediatric nephrologists should ideally be well suited to promote this. There's another prophylactic medicine called EvuShield, which is worth talking to your healthcare providers about. And then masking to prevent spread when community transmission is high, I think makes sense. And then just really paying attention to who those highest risk transplant patients are. Anyone who's had a transplant in the last 3 to 6 months, if anyone's on higher than baseline immunosuppression, for example, recurrence of a disease or treatment of rejection, and any of those more worrisome comorbidities like we talked about. So cancer diagnosis, lung disease, obesity, things like that. And generally this is our motto, right? Together we can swim better. So as Rouba said, pediatrics, we're a pretty small community. So when we have challenging questions, we try to come together and figure things out. So with that, I just wanted to say a quick thank you. All of this data was collected by IROC researchers and clinical staff. This was totally voluntary. I didn't pay anybody for any of this. So it's a pleasure to work with everyone, particularly the patients and parents throughout IROC who really were the inspiration for this work. I mean, they were the ones showing up to our first IROC call saying, hey, figure this out. And so we said, okay. And so That's all we have from a slide standpoint. And I don't know, Amanda, if you were going to pop back in and see if we can talk about some of these questions potentially that are showing up in the chat.
We do. Well, I want to thank everybody for participating, and especially to Dr. Garro and Dr. Varnell for their great presentations. I know that I've learned a lot. And as the co-chair of the Community Engagement Work Group, I really appreciate that we appreciate all the work that you're doing on a volunteer basis. So thank you so much. We actually have some questions for you. So the first question is from Melissa. She asked, what rough percentage of rejection episodes are from non-adherence?
Sure.
Yeah. Go ahead.
I'll take a first stab at it, and please fill in if you have something better here, Dr. Garro. So there's some old data that's really specifically this. When I say old, I mean about 10 years old. That estimates about 40% of graft losses are due to non-adherence. And so I haven't seen more updated data than that one kind of larger systematic review that's come out. But that's our best guess from right now that I'm aware of.
Yeah, and it depends on the age group, right? I mean, you're going to see different percentage based on the age group. I mean, we tend to see less of issues with non-adherence in younger age groups where the medications are, the parents are in control, right? So that's where we usually tend to say we have better outcomes in the younger children because for the most part, parents are in control, and it's just the rocky transfer of responsibility that I was talking about that needs to be done properly, and then we get into that age group. But I agree. I mean, I'm not aware with any other data, Chuck, but I guess that's going to be related as well. It's going to be depending on the age group.
So we actually have another question about non-adherence from Melinda, and she asks, is there evidence that non-adherence is the top factor for rejection in that age group? I'm wondering if perhaps hormonal changes or rapid growth might be a factor as well, especially if medication does stay the same while they go through the rapid growth.
It's a good question, and I'm sure these factors play a role. Luckily, that's why in pediatric ward we monitor drug levels very closely, and so we can count for these changes. And that's again that chart I showed, because like younger children, for instance, they metabolize medication faster. So we have to adjust medications as we're going. So definitely there are those factors that can play a role related to growth, to puberty, and changes that the body is going through. But that's why we always try to get frequent labs so we can count for these changes.
And I was just going to piggyback on top of that. I think certainly the developmental, pharmacokinetics throughout adolescence and development play a role here. But you hear us, we kind of harp on adherence more than these other things because it's a potentially modifiable factor, right? It's something that if we can identify it, we might be able to work on it. Whereas, your body's biochemical changes, we're not going to be able to have an effect on that. So like Dr. Garro said, just close monitoring as best we can.
Yeah. So I just want to remind our viewers if they want to ask questions, to throw them in the chat. I have a couple more questions though from our listeners. So the next one is from Caitlin, and she wants to know, has there been any consideration to training caregivers to take manual blood pressure to help data points for whether their hypertension is well controlled?
I can take stab on that. So again, it's risk and benefit. So even if you looked at our protocol, even across IROC, even as a center, we allowed to start with automated blood pressure. So it's not necessarily it's a bad choice. I mean, definitely manual is more accurate, but if the blood pressure is consistently normal on automated blood pressure, I think that provides good enough data. Plus, we do look at other things like end organ damage, where we do the echo, make sure there is no thickness of heart muscle. So there are other things we look at. But I think if the blood pressure is consistently normal on automated blood pressure, I think that should be good enough. Again, because convenience matters, right? I mean, our patients, and families dealing with chronic disease, right? And as you saw in our slides, quality of life is important. So we need perfection. We need to improve outcome, grafts, and patient survival, improve patient survival. But at the same time, we want to maintain quality of life. So definitely, we've trained parents to do manual blood pressure, especially in smaller kids when you don't have easily available automated blood pressure that you can purchase from pharmacy or Walmart. So then our only go-to is manual blood pressure. But again, it can be tricky even with smaller kids. So really it depends on the situation, and convenience is important. And again, we use it even as a screening tool in some centers. So I don't know what you do, Chuck. I mean, with the manual blood pressure, it's Cincinnati. Do you train your parents frequently?
I think there's some patients that particularly are motivated and want to learn how to do it, and certainly in those cases we do. I agree. The automated blood pressures, when we feel like we have good control, are great as a screening tool. I think this raises a really great question, though, as far as adding data points, right? And I think the next 10 years, we should hopefully be moving more towards patient-reported outcomes. So the patients and the families being able to give us data from your lives, particularly when we start thinking about quality of life, value of healthcare. That's really hard for us in the clinic to measure. And so whether it's data points like adherence at home when you're not in the clinic, or thinking about your blood pressures, I think there's going to be a big move in this space in the next couple of years that we're just now starting to figure out how to work with.
So we have just a couple of general questions, and I know that just from my own experience, one of the questions was, how long do pediatric transplant last? And I think it goes back to what you were talking about earlier about adherence. And is there a direct correlation with the better that you take care of yourself and take your medications, the longer your transplant will last? So if either one of you wants to take that question, how long do transplants last, pediatric transplants?
Sure, I'll take a first step. By all means, Dr. Garro, add to it. But it depends on a lot of different factors, right? So is it a living donor kidney, a deceased donor kidney? I think it's important that we talk about the things that we can do to keep our kidney healthy, which includes taking medication, healthy diet, healthy exercise. But that being said, we all know examples of people that have lived perfect lives and things don't go the way they're supposed to, right? You can get a heart attack you never knew, despite the fact that you're running marathons. And so I don't want to connect too much between, oh, your kidney didn't last long enough if you don't take your medicine the right way. There's so many factors that can play in here, but in the ideal state, yeah. Living kidneys, we think the half-life is somewhere in 15 to 17 years, meaning half of them are still working at that time, half of them aren't. Deceased donor kidneys are a little bit lower at more like 12 to 15 years. And there's a lot of things that play into that. And so this is why we try to find the things that we can control. So it's hard for us sometimes to control your disease state or maybe your immune response as much as we try with medications. But taking meds, healthy lifestyle, diet and exercise, those things are only going to help these outcomes in the long run.
So I'll just jump in to say, I think for me as a parent, as a caregiver of a kidney transplant recipient, you hit the nail on the head. It's about what we can control. And we can control, well, as a parent, I can't control my daughter's diet, but we try as best as we can. But that's exactly what we're always trying to think of, is what we can control and to have the best outcomes.
Yeah, and I agree. I mean, it's very important to recognize that when we're talking about non-adherence, we're not saying it's the only reason for graft loss. So, and as Chuck mentioned, that alluded to that nicely, it's one of the things we can control. There are certain things immunologically we cannot control. We see that sometimes with smaller kids. Sometimes viral infection trigger their immune system to react in certain ways. We see some with COVID, but some with regular viruses. And there are certain things we recognize as a community, as a transplant community, that we're still not doing great, right? By asking patients to take medications twice a day. We know it works, but again, it's not convenient. And we know we need to do better. We know some of the medications like Prograf, which is one of the most potent immunosuppressive medication that decrease risk of rejection quite a bit. But we know it can be harsh on kidneys long term. So we all as community trying to be as scientists and researchers trying to do better. And even work to address all the issues from all angles, right? What are we doing wrong with medication? Can we do medications that doesn't cause any toxicity to kidney and prolong the life of the kidney? And that is a field that people working very hard on, and working on blood pressure and cardiovascular risk factors. We're working on individualizing immunosuppressive medications based on different immunologic risk factors, and having and then the adherence part, right? So I think it's a collaborative work and from different angles.
So it looks like we have another question from Catherine. She's asking, what percentage of kidney transplants later on in life are driven by other transplants?
Say it again. I'm sorry. Can you repeat the question?
Sure. What percentage of kidney transplants later on in life are driven by other transplants? So I'm not
like
sure.
other organ, like combined organ transplants.
Well, yes, let's take that perspective. Yes.
Like how many is heart kidney, how many liver kidney? Is that the question?
Sure. Let's go down that.
Yeah, I'm not sure about so in adults, a huge percentage would be pancreas kidney. So because of if that's the question, I'm sorry if I didn't understand it correctly, but in adults, you will see a lot of combined pancreas kidney transplant because of the prevalence of type 2 diabetes and diabetes generally speaking. So you will see big proportion in adults are combined pancreas kidney.
So somebody was asking, they clarified, if you have a lung transplant as a pediatric patient, then does the kidney fail later?
Yeah, I mean, we see that with heart transplants quite a bit, that we end up many, they may, I don't have numbers, but we see it with heart transplant because it's multiple hits. It's when you have a heart failure at one point, you're not perfusing the kidney, so the kidney is injured slowly initially, and then you get the heart transplant and you are on immunosuppressive medications that can be toxic to the kidney. So you can see some of that. You may see it with liver transplant sometimes, especially if they have some diseases like can hit both, and the liver gets hit first, like autosomal recessive polycystic kidney disease. Sometimes they may start with liver transplants and then they end up needing kidney transplants. So certain diseases can affect both, but more severe one organ initially that end up with another transplant. Lungs, I'm not sure if it's one of those that stick out there. I would think more liver end up transplant and end up with a kidney, heart end up with a kidney. What do you think, Chuck, about that question?
Yeah, we occasionally see it, but it's not very common in pediatrics. I think we probably see more chronic kidney disease in those patients with other transplants who have been on, calcineurin inhibitors, tacro and cyclosporin. Usually by the time we're seeing them, it's been 15, 20 years on that medication before you start seeing kidney injury. But it occasionally happens, but it's so uncommon that, I've got to stretch to think of the number of patients that I've seen make it to transplant. That's probably more likely happening in the adult side after they've transitioned out from our standpoint.
And that follow-up question, I think, from Catherine, are these transplants that they need later in life, is it due to the toxic nature of the medications?
Certainly a contributor.
For the most part, unless there is a second hit, as I said, either it depends on the underlying disease. So if there is something that can eventually affect, and with the heart, as I said, when you have a heart failure at one point, you're not perfusing the kidneys. So.
Well, I want to thank you both. If there are any final thoughts that you would like to share with the group.
I think we're humbled to be here, and we thank all of you first for inviting us and for all the work you do, taking care of your kids and patients, and for contributing to the science of pediatric transplantation, and to keep us checked, in check. We love that.
Agreed.
Well, I just want to announce that, and I don't know if I'm pronouncing the name correctly, but Daniel Michon is the participant that won the door prize. So congratulations, Daniel. You'll be receiving an email with that prize information. So just want to close and say thank you so, so much to Dr. Garro and Dr. Varnell for your insights and for answering all these questions on the fly. And so with that, we're going to end the session. And thank you again for attending.
Thank you.
Thank you very much.